Welcome back. In today's session, we are going to discuss about diphtheria. It is a continuation to the topic epidemiology of communicable diseases. The objectives to this session are introduction to diphtheria, problem statement, epidemiology, clinical presentation, which is nothing but the signs and symptoms of diphtheria, followed by the complications, diagnosis, prevention and control, and lastly, we will discuss about the general management to diphtheria. To begin with the introduction, diphtheria is an acute infectious disease caused by toxigenic strains of Corynebacterium diphtheria. So here we see the causative factor to diphtheria. What is the factor which is causing the diphtheria? It is Corynebacterium diphtheriae. You can see the picture here, Corynebacterium diphtheriae here. And these Corynebacterium diphtheriae are releasing this toxigenic strains. What do you mean by a toxigenic strain? They are a group of organisms that will produce the toxins and they cause the disease diphtheria. The bacilli will multiply locally. So we see once the bacilli is entering the respiratory tract, it is multiplying locally there. Usually it is multiplying in the throat and elaborates a powerful exotoxin. So we see that this bacilli is elaborating an exotoxin, and this exotoxin is responsible for the formation of grayish or yellowish membrane. Diphtheria, you have to mainly remember there is a false membrane formation, pseudomembrane, and what is the appearance of this membrane? It is grayish or yellowish membrane. It is a false membrane. It is commonly covering the tonsils, pharynx, larynx with a well-defined edges and membranes which cannot be wiped away. So this pseudomembrane has well-defined edges. The membranes, the edges are clearly defined. They are well defined, and these membrane cannot be wiped away. You can see in the picture here diphtheritic membrane, a pseudomembrane which is formed by the Corynebacterium diphtheriae locally in the throat, and also there is marked congestion, edema or local tissue destruction. Followed by there is enlargement of the regional lymph nodes and the signs and symptoms of toxemia. So what are the signs and symptoms we see in cases of toxemia? The patient can have blurred vision, nausea, headache, swelling in the extremities, weight gain, or he could also experience fatigue or blood pressure, the high blood pressure. Moving further to the problem statement of diphtheria. Diphtheria in the developed countries will occur rarely, whereas in the developing countries it is endemic. The true number of cases of diphtheria and the deaths are exactly unknown because there is incomplete reporting of the diphtheritic cases in most of the countries. Because of the reporting is not done properly, people are not reporting to the authorities. So what's happening? The cases are not getting recorded. As a result, we don't know exactly the number of cases which are present. In India, it is an endemic disease. What do you mean by an endemic disease? Endemic diseases are those which are having a usual frequency. Now let us consider an example. Now in India, if the number of cases in this region are 100 and it is an endemic in that area, it means the next year again the frequency is going to be in and around 100. So the endemic cases are those which are persistently present, having the usual number of the frequency each year. And the declining trend in the diphtheria is because of the increased coverage of the child population by immunization, because of the increased immunization which is followed, because of the vaccines which have introduced newly, that is causing a decline in the number of cases of diphtheria. In 1987, the number of cases reported were 12,952, whereas in 2013, it has come down to 4,090. You can see a drastic change in the number. It is because of the immunization of the children which is done. It is declined by 68%. Moving further to the epidemiological triad of diphtheria, we have agent factor, host factor, and environmental factor. A very important aspect from the SPM point of view is the epidemiological triad. Even from your exam schedule, it is very important that you need to focus on the epidemiological triad in cases of your community medicine. So let us focus on this part now. Epidemiological triad, the triad consists of agent, host, and environment. The agent factor, we are very well aware of the causative organism, that is Corynebacterium diphtheriae. Then the host factor are usually the children less than 5 years of age, and the environmental factor, we have winter months. So let's begin with the agent factor. Agent is Corynebacterium diphtheriae, which is a gram-positive, non-motile organism. You can see the picture of the Corynebacterium diphtheriae here, which is a non-motile organism, and it is a gram-positive organism. It has no invasive power, but it is producing an exotoxin. So they elaborate powerful exotoxins. These exotoxins are responsible for the formation of the pseudomembrane. Moving further to the source of infection, the sources of infection are the cases and the carriers. Cases could be subclinical cases or clinical cases. Case, what do you mean by case? Case is a person who is infected and he is displaying the signs and symptoms of the disease, whereas carriers are the more common sources of infection in cases of diphtheria. Now, who is a carrier? Carrier is a person who is infected but he is not showing any signs and symptoms of a disease, whereas cases display those signs and symptoms, but carriers, we cannot recognize the actual signs and symptoms. They are not evident in the carriers. As a result, they are the more common sources of infection. 95 carriers are present for 5 subclinical cases. Carriers could be temporary carriers or chronic carriers, nasal or throat carriers. If the diphtheria is affecting the nose, they constitute the nasal diphtheria and they are the nasal carriers. If it is affecting the throat, we have the diphtheria carriers who are affected by the throat. Nasal carriers are particularly dangerous source of infection because of the frequent shedding of the organism into the environment than the throat carriers. Nose carriers, they are more dangerous because they keep shedding the organism in the environment. The temporary carriers may last for about a month. So we have temporary and chronic. Chronic lasts for a longer period, whereas temporary carriers will last just for a month. Chronic carriers will persist for a year or so unless the patient is treated. Moving further to the infective material. The infective material in diphtheria is the nasopharyngeal secretions, discharges from the skin lesions, contaminated fomites, and infected dust. So we see if the person sneezes, coughs, the droplet nuclei or the droplets of the infection which falls on the objects, they form the contaminated fomites. Contaminated fomites could be the water bottle, the pen, table, whatever. If the patient sneezes and the droplets fall on that particular object, it turns into a contaminated fomite. The period of infectivity, it varies from 14 to 28 days from the onset of disease, but the carriers may remain infective for a much longer period. The infectivity just ranges from 14 to 28. Just the onset of the disease, it will last up to 14 to 28 days the person can be infective. But whereas the carriers, they are remaining infective for a much longer period. Moving further to the host factor. Diphtheria particularly affects the children aged 1 to 5 years. It affects both the sexes equally. And moving further to the immunity. Infants who are born of the immune mothers are relatively immune during the first few weeks or months of life. We see diphtheria is having the maternal antibodies are going to provide the immunity to the newborn infant for few weeks or just for few months of the life. Moving further to to the environmental factor, it occurs in all the seasons, although the winter month will favor its spread. In Kolkata, the highest incidence of diphtheria was reported in the month of August, in Mumbai in winter months, and in Delhi during August to October. Moving further to the mode of transmission of diphtheria. As I discussed earlier, it is mainly transmitted through droplet nuclei. It can also be transmitted directly to susceptible person from the infected cutaneous lesions, the skin lesions. As you can see in the picture here, it can also be transmitted through the cutaneous lesions. Moving further to the portal of entry of diphtheria. It could be the respiratory tract, which is the most commonest route of entry. The non-respiratory routes include the skin, where there are cuts, wounds, ulcers. It could also be the umbilicus in the newborn infants. You can see in the picture here, it is the respiratory tract which is the most common route of spread, and the others are the cuts, ulcers, wounds and umbilicus in newborn. Moving further to the etiopathogenesis of diphtheria. The bacilli will enter through the upper respiratory tract, and it will remain confined to the site of the entry, where they will multiply and produce the diphtheritic toxin. So you can see in the picture here what's happening. The bacilli is entering the upper respiratory tract. Okay. The bacilli, it will enter the upper respiratory tract and it will remain localized in that respiratory tract, and it produces powerful exotoxin, which is nothing but the diphtheria toxin. The toxin is causing the local necrotic changes. Once there is inflammation, then comes the necrotic changes along with the superficial inflammatory changes. As I said you, first the inflammatory changes will occur, followed by the necrotic changes. The necrosed epithelium together with the fibrinous exudates, the localized leukocytes, erythrocytes and the bacteria together constitute the greyish pseudomembrane, which is the characteristic feature of the diphtheritic infection. Let us repeat. So this diphtheritic membrane, what does it constitute? One, the bacilli, which is locally causing the inflammatory changes, and then necrotic changes. It is causing the necrotic changes. And this necrosed epithelium, what does it contain? Let us have a clear picture here. This diphtheritic membrane is containing the necrosed epithelium followed by exudate. What exudate? Fibrinous exudate, and leukocytes, erythrocytes and the bacteria together constituting the greyish pseudomembrane. The membrane extends from the oropharynx to the larynx and then into the trachea. The mechanical obstruction of the trachea by the pseudomembrane can cause the suffocation and it will lead to death in the patients. So these pseudomembrane which are formed in the throat, they will cause obstruction of the trachea and there will be suffocation in the patient and he will die. Moving further to the incubation period of diphtheria. It is 2 to 6 days. Sometimes the incubation period could be much longer than it. So we will move further to the clinical features of diphtheria. Respiratory tract forms the diphtheria consist of pharyngotonsillar diphtheria, laryngotracheal diphtheria, nasal diphtheria, and it could be a combination of these. We will discuss about each of these subtypes in detail in our upcoming slides. Pharyngotonsillar diphtheria. Pharyngotonsillar diphtheria consists of sore throat, difficulty in swallowing, low-grade fever. At presentation, there is a presence of pseudomembrane over the tonsils. Since it is a pharyngotonsillar diphtheria, the pseudomembrane will be formed on the tonsil. There is edema which is present in the submandibular region, which gives a bull neck appearance. So we see in the picture here the bull neck appearance. there is a pseudomembrane formation on the tonsils. Here you can have a picture. Diphtheria, we are noticing a pseudomembrane in the posterior pharynx on the tonsils. Now it can cause an obstruction of the airway, causing suffocation and death. Patient also presents with the difficulty in swallowing because of the pseudomembrane which is present there. It is causing an obstruction, so the patient has a difficulty in swallowing. Moving further to the laryngotracheal diphtheria. It is preceded by the pharyngotonsillar diphtheria. The patient presents with fever, hoarseness of voice, and croupy cough. We see the larynx, the voice box being involved here. So the patient presents with hoarseness of voice. There is hoarseness of voice and also a croupy cough which is present, and he also presents with dyspnea. Moving further to the nasal diphtheria. Nasal diphtheria is the most mildest form of diphtheria. There is a localized in the septum or turbinates of one side of the nose. You can see in the picture here the pseudomembrane or the diphtheritic membrane. It is localized to one side of the nose, one turbinate of the nose, or it is also present on the septum of the nose. Conjunctiva and genitals are also the sources of infection. We have membrane which is later extending into the pharynx. So what are the three types we saw? The nasal diphtheria, most mildest form. It is found in the septum or in the turbinates of the sides of the nose, and then the membrane can extend into the pharynx. Then in the laryngotracheal, you can see in the laryngotracheal we have swollen lymph nodes, fever, hoarseness of voice, croupy cough, and also dyspnea. In the pharyngotonsillar, there is hoarseness of voice, difficulty in swallowing, fever, and pseudomembrane formation over the tonsils, edema of the submandibular region, and bull neck appearance. It could be an MCQ in your entrance exams. The bull neck appearance is found in diphtheria. Moving further to the cutaneous diphtheria. Cutaneous diphtheria is common in the tropical areas. The secondary infection of the previous infection or skin abrasion. So cutaneous diphtheria is nothing but a secondary infection of the previous infection or the skin abrasion. The presenting lesion is an ulcer which is surrounded by erythema and it is covered with a membrane. You can see the presenting thing is an ulcer, and the ulcer is surrounded with redness. There is erythema and also it is covered with a membrane. It is a picture of the cutaneous diphtheria. Here is a case of a 10-year-old boy with a severe diphtheria. He is presenting with conjunctivitis, the pharyngeal membrane, bull neck which is severe. You can see the bull neck appearance. There is a swelling of the submandibular region, the swollen lymph nodes, and he also presents with myocarditis, which is one of the complications of diphtheria. Moving further to the complications of diphtheria, in the cardiovascular system, diphtheria, you can see it is causing myocarditis, arrhythmia, and chronic heart failure. Cardiovascular complications usually occur after the 1 to 2 weeks of the illness. The patient starts with diphtheritic complications like myocarditis, arrhythmia, and chronic heart failure. In the respiratory system, it causes respiratory failure. Renal system, it affects the kidneys, causing tubular necrosis and proteinuria. Affecting the neurological, that is the central nervous system, it is causing the palatal palsy. The palatal palsy will occur in the second week. Nasal regurgitation of the fluid because of the palsy. There is regurgitation of the fluid. Nasal intonation of voice. When the patient speaks, he has this nasal voice. Nasal intonation of voice could be present. Ocular palsy occurs in the third week. Neurological, it's very important to remember in the complications. Myocarditis, arrhythmia, chronic heart failure. In respiratory system, respiratory failure. In the kidneys, it will cause tubular necrosis and proteinuria. In the neurological, it will cause palatal palsy and ocular palsy. Palatal palsy in the second week, Ocular palsy in the third week. Ocular palsy, there is a deviation of the eye. There is loss of accommodation and blurring of the vision. The generalized polyneuritis is seen from third to sixth weeks. Is it clear, guys? We have loss of accommodation in the eyes, blurring of the vision, polyneuritis in the third to sixth weeks. Moving further to the diagnosis of diphtheria, we need to take the clinical history. In the clinical history, we may consider the following factors when diagnosing diphtheria. It could be the age of the patient. Typically, diphtheria occurs in the children less than 5 years of age. Exposure, the patient if he's exposed to an infected person, or if he has traveled to an area where the diphtheria was an endemic disease or an epidemic disease. Then we will discuss about the vaccination status of the patient. This is about the clinical history, what you're going to ask the patient. One, if he is traveled to any area where the diphtheria was an endemic disease or the diphtheria was an epidemic disease, and we're going to ask if the patient was vaccinated completely or not. And the symptoms, in the clinical history we take the symptoms of the patient. The symptoms could be the sore throat, fever, the bull neck appearance, weakness, fatigue. And we'll also examine and identify the diphtheria bacilli from the site of the lesion. What are the tests we are going to perform? We will do the culture of the Corynebacterium diphtheriae. We may take the culture material from the patient's throat membrane, that is from the diphtheritic membrane, the pseudomembrane. We will take the material and we will grow the Corynebacterium diphtheriae and confirm our diagnosis that it is caused by Corynebacterium diphtheriae and it is diphtheria. For cutaneous diphtheria, we can take a tissue sample of the infected wound. Then comes the Albert's stain. What is Albert's stain? Albert's stain is a microscopic test which helps us to identify the Corynebacterium diphtheriae which is causing the diphtheria. This test is performed by staining a sample from the patient's throat, or we collect in cutaneous diphtheria. If we collect it from the wound or a tissue, we will stain this sample with a special solution. And we can also take the swabs from the patient's throat, from wounds or tissues. We collect the sample and then that sample we are staining it with Albert's stain, and this will highlight the metachromic granules which are present in the Corynebacterium diphtheriae. You can see in the picture here the Albert stain which is highlighting this metachromic granules in the bacteria. And now we will examine this sample under a microscope and we will observe that blue-black color of the granules, and then we will confirm that it is Corynebacterium diphtheriae and the patient is having diphtheria. Now we will move further to the control of diphtheria. In the control of diphtheria, we have to discuss about the cases, the carriers, contacts, and the community. To begin with, the cases. The cases when the diphtheria is suspected, you can see whenever the diphtheria is suspected in a patient, the diphtheria antitoxin should be given without any delay. Either IM or IV has to be given. The diphtheria antitoxin should be given without any delay. Now let us see. We are going to give the antitoxin, and before that we need to do the isolation. We have to detect the cases and the carriers, do the isolation of the cases and the carriers in the hospital for at least 14 days until they are proved free of the infection, and at least 2 consecutive nose and throat swabs have to be taken 24 hours apart. We need to take the throat swab, check 24 hours apart, take the throat swab, check if the tests are negative. Before terminating the isolation, we need to confirm that the diphtheria tests are negative. And then we will give the treatment of the cases and the carriers. In the treatment, let us discuss for the cases what treatment is given, and for the carriers what treatment is carried out. For the cases, as I said you, as soon as the diphtheria is suspected, we give the diphtheria antitoxin without any delay. It is given IM or IV in the dose which is ranging from 20,000 to 1 lakh units. Depending upon the severity of the case, we give Diphtheria antitoxin 20,000 to 1 lakh units. After a preliminary test dose has to be done. 0.2 ml subcutaneously we need to inject the diphtheria vaccine and we need to test it and then detect the sensitization to the horse serum. Now let us see. Subcutaneously we sensitize it to the horse serum and then carry on the full procedure. For the cases, let's see what is the dose of the diphtheria antitoxin given. If the case is a mild early pharyngeal or laryngeal case, the toxin dose is 20,000 to 40,000 units. If it is a moderate nasopharyngeal diphtheria, in cases of nasopharyngeal diphtheria which is moderate, the dose is ranging from 40,000 to 60,000 units, whereas in severe, extensive or late cases it is 80,000 to 1 lakh units. Moving further, in addition to this antitoxin, every case should be treated with penicillin or erythromycin for 5 to 6 days to clear the throat of Corynebacterium diphtheriae, and thereby we are decreasing the toxin production. So we see apart from this antitoxin, based upon the severity of the case, it is from 20, 40, 80. Apart from this, we are giving penicillin or erythromycin for all the cases for 5 to 6 days so that we can treat the Corynebacterium diphtheriae and decrease the toxin production. Moving further to the treatment of the carriers should be treated with 10 days course of oral erythromycin. The oral erythromycin is the most effective drug for the treatment of the carriers. The immunity status should be upgraded, as we are going to discuss above. The immunity status also has to be declared even in the carriers, and the treatment given is erythromycin for 10 days. Moving further, in cases of contacts merit the special attention because we know they don't exhibit any evident signs and symptoms and they spread the infection in the community. We need to give a special attention to the contacts. They should be throat swabbed and their immunity status has to be determined. Where primary immunization or booster dose was received within previous 2 years, no further action is required. So we see different situations are posing different options. So when the primary immunization was just received or the person just received a booster dose, in such a condition we don't have to need there is no further treatment or action required because it is just within 2 years he has received a fresh immunization or he has received a booster dose. The non-immunized close contact should receive a prophylactic penicillin or a prophylactic erythromycin and 1000 to 2000 units of diphtheria antitoxin. So we are seeing that in cases of the contacts who have non-immunized, these contacts are non-immunized. So we are starting with penicillin or erythromycin followed by 1000 to 2000 units of diphtheria antitoxin is given. The contact should be placed under the medical surveillance and examined daily for at least a week. We need to examine the contacts under the surveillance. Moving further to the immunization status, let's have a quick review about it, what we discussed in the previous slide. If his primary immunization is already done or he's just received the booster dose within 2 years, then no further action is needed. If the primary course or booster dose is received from more than 2 years apart, then we have to give him 1 booster dose of diphtheria. So 2 years and above, before 2 years he has taken the diphtheria the vaccine or the booster dose is received before 2 years, then 1 booster dose has to be given. For the person who is non-immunized, then the prophylactic penicillin or erythromycin has to be given. The diphtheria antitoxin 1000 to 2000 units have to be given, and the primary course of 2 doses and a booster is followed. Moving further to the community. So in the community, we see the active immunization with the diphtheria toxide of all infants as early in life as possible as scheduled has to be done with the subsequent booster doses every 10 years thereafter. So we see active immunization is done of all the infants as early as possible. Immunize the infants. Once this is done, subsequently we are giving booster doses every 10 years thereafter. Moving further to the DPT vaccine. The DPT vaccine, for immunizing the infants, the preparation of choice will be the DPT. And firstly, because the infant can be immunized simultaneously, we will also include the component diphtheria, pertussis and tetanus. So we see pertussis component, it is enhancing the diphtheria toxin. So DPT vaccine could be plain vaccine or an adsorbed vaccine. The absorption carried out on a mineral carrier like aluminium phosphate or hydroxide. We see this adsorption. Now, what are the two types of DPT vaccines? What you have to remember under the DPT vaccine, it is used for immunizing the infants, and these infants are simultaneously immunized with diphtheria, pertussis, tetanus, and we are including the component pertussis, which is enhancing the diphtheria toxin. And what are the types of vaccines? We have a plain vaccine or a adsorbed vaccine. Adsorbed vaccines, the adsorption is carried out on a mineral carrier like aluminium phosphate or aluminium hydroxide. What is the use of this thing? This aluminium phosphate or hydroxide? Why are we doing this adsorption? Because this adsorption will increase the immunological effectiveness of the vaccine. Since the effectivity of the vaccine is increased, we are preferring to adsorb this vaccine on a mineral carrier like aluminium phosphate or hydroxide. Moving further to the storage of the DPT vaccines, it should not be frozen. It should be stored in the refrigerator at a range of 2 to 8 degrees Celsius. Will lose potency. These vaccines will lose the potency if they are kept under a room temperature for a long time. Moving further to the optimum age. It has been found that young infants, they respond well to the immunization with potent vaccine and toxoids even in the presence of moderate levels of maternal antibodies. Even if the maternal antibodies are low, even if the maternal antibodies are to a moderate level, the infants will respond very well. Young infants are responding well to the immunization. According to the Global Advisory Group of the Expanded Program of Immunization, which is nothing but EPI, the Global Advisory Group of EPI. EPI stands for Expanded Program on Immunization. It has recommended that DPT vaccine can be safely and effectively administered as early as 6 weeks after the birth. So soon after 6 weeks after birth, the diphtheria vaccine, DPT vaccine, can be administered to the infants. The dose, 3 doses of DPT, each is 0.5 ml. What is the dose of the DPT vaccine? It is 0.5 ml and 3 doses of DPT is given. Mode of administration of DPT, all the vaccines which are containing the mineral carrier, like we discussed the aluminium phosphate or aluminium hydroxide. So the vaccines which are containing mineral carrier should be injected intramuscular. DPT given in upper and outer quadrants of the gluteal region. Moving further to the immunization schedule, it is 6 weeks, 10 weeks, 14 weeks, 16 to 18 months, a booster dose is administered, and the booster dose are also given at the age of 5 years. Is it clear? What is the immunization schedule? 6, 10, 14. You can add plus 4, 6 plus 4, 10, 10 plus 4, 14. You can remember like this. 6 is the number you have to remember. Plus 4, plus 4, plus 4. 6, 10, 14 weeks, 16 to 18 months a booster dose, and 5 years. Moving further to the reactions of the DPT vaccine, fever or mild local reactions can be seen. 2 to 6% patients will develop fever of 39 degrees Celsius or higher, whereas 5 to 10% of the patients will experience swelling or induration. The neurological reactions could include the encephalitis, prolonged convulsions, infantile spasms, and Ray's syndrome. So we see the mild local reactions and fever, following the DPT immunization, which is very common. Whereas the most severe complications, what are the severe complications? They are neurological, like encephalitis, prolonged convulsions, infantile spasms, and Ray's syndrome. In Ray's syndrome, you can see that there is inflammation of the liver and the brain tissues, there is encephalitis and hepatitis. Moving further to the contraindications of diphtheria. Vaccine, they are seriously ill children or who need hospitalization are not usually vaccinated. So what are the contraindications? Minor illnesses like that, cough, cold, fever and all, they are not considered as a contraindications to vaccination. Only the children who are seriously ill, who are hospitalized, they are not to be vaccinated. DPT should not be repeated. If a severe reaction has occurred from the previous dose, we should avoid repeating the DPT vaccine. Such reactions will include the collapse or shock like state. It is persistent screaming episodes, or the temperature is ranging above 40 degrees Celsius. If the infant is having convulsions, neurological symptoms, so these are the contraindications. In cases of DPT, subsequent DT immunization has to be done. So since the severity of the pertussis infection is decreasing, the pertussis component from the DPT is not usually recommended for the children. So we see that in cases of DPT, DT immunization, we are eliminating the P. Pertussis is eliminated. Component is not usually recommended after the age of 6 years because the pertussis infection is decreasing these days. So the pertussis component has been removed and only the DT vaccination is done for the children, and 2 doses of the DT vaccine is given from the 4 weeks apart. Moving further to the management. If any suspected diphtheria, immediately you need to start the treatment with antitoxin and antibiotics like erythromycin, penicillin. Antitoxin is a mainstay of the treatment to neutralizing the toxin that is not bound to the tissue. We see the mainstay of the treatment in diphtheria is the antitoxin. Antibiotics which are used to eradicate the organism and to prevent the spread. We are also using the antibiotics which are used to eradicate the organism and we are preventing the spread. The mechanical ventilation can be given if at all it is needed, and the dose of the antitoxin will depend upon the extent of the disease, the severity of the disease, as we discussed in our previous slides. The antibiotics, as I discussed earlier, are the penicillin and erythromycin, and we also treat the carriers. Thank you. With this, we come to an end of the session diphtheria. I hope everything is clear. If you have any doubts, put them down in the comment section, and if you like the video, hit the like button and subscribe.